So today I was just going to talk about some social determinants of health and really focus on the effects of food insecurity on our diabetic population. Next slide. And so food insecurity was defined by the World Food Summit as everyone at all times having physical and economic access to sufficient, safe, and nutritious foods that meet their dietary needs for an active and healthy lifestyle. And that sounds fine, but we also have to still consider socially and culturally acceptable types of foods. And then in the context of diabetic patients, not only do they have to have access to that sufficient quantities of food, that is also important just to guarantee food security, especially if the food quality and preferences are ignored. So, if we don't take that all into consideration, that can also affect their security. Next slide. You can go to the next slide. So I read a study that's called The Intersection Between Food Insecurity and Diabetes. It was in the nutrition reports. And it was really interesting. It honed in on a lot of these aspects that sometimes we don't always think about with patients. But we have to always consider why patients might not be well controlled. And sometimes it's just that they're having issues with food security. And sometimes they get caught up between just competing priorities, such as having enough foods, having their medications and supplies. And sometimes just simple things like having money to pay rent, that they may opt to pay those things rather than pay for their medications or get proper amounts of foods. And so the vulnerable populations that we have to really be aware of are those that are the female lone parent households, elderly patients, recent immigrants, health impaired, and or those with low income. And as I said, just they have limited budgets sometimes, so they might be purchasing foods that are higher in calories, that might be less expensive. And it does make them more susceptible to developing diabetes and also worsening diabetes if they are already diagnosed. Next slide. So the prevalence in diabetics in the US is about 10% in food insecure households compared to 7.4 in those that are more secure in their foods. And then as the food insecurity worsens, it increases their prevalence of diabetes as well. Next slide. Next slide. So we know just by, studying these that most patients that are in food insecure environments that have higher A1C levels, they may have more hypoglycemic episodes and will also sometimes have higher BMIs just based on the kinds of foods that they're consuming. Next slide. So the ADA does address upon the psychosocial aspects of food insecurity and really just things that are affecting control. And so things that you might think about asking at the visit, if they are really uncontrolled in diabetes, sometimes they'll actually lose weight because they're forcing a lot of calories out through the urination. So if they're, say not paying for their medications or taking them because they're more worried about food intake, then they could actually lose weight. Some may gain weight just because they're eating foods that aren't as healthy. You want to ask them about their compliance and why, what might be kind of the things that hold them back from getting things under control. And then, of course, like I said, poor diabetes control, but also the psychological aspects of depression and anxiety and any sort of emotional distress that they might be experiencing. Next slide. So a lot of people who are food insecure, I found in my own practice that they will buy more inexpensive foods, which sometimes are packed with carbohydrates. I've seen them skip meals. Sometimes they cut their meal sizes and they'll eat stale foods. And they'll sometimes purchase things like in bulk. They may only purchase stale items that might not actually be, conducive to a diabetic diet. They'll consume seasonal foods, frozen foods sometimes. They'll comparison shop. Some actually shop with their friends or neighbors and they split food. Sometimes they get food from relatives, food banks, things like that. I haven't really had this experience, but in the article it did mention that, sometimes adults just maybe not eating as much because they're saving that for their children. Next slide. Next slide. So the ability to access and prepare healthy foods may also be an issue. So if they're eating from the convenience stores, those might contain things that are low in nutrition and sometimes more expensive. Sometimes if they don't have a place to cook food, they might just buy something that's like easily eaten or doesn't really need much preparation. And those items could be really high in salt, which just exacerbates some of the complications that we deal with in our diabetics, such as hypertension. And then, of course, as I said before, they might opt to, purchasing their medications and supplies, over food or vice versa. Next slide. And then sometimes they'll delay filling scripts. I've had patients reuse needles months upon months. And that does become an issue for infection, as well as just the needles become very dull and makes it more difficult to inject insulin. And oftentimes, if they're not checking very often, it just might be that they don't have testing supplies to do so. Next slide. And sometimes they have to choose between healthy foods and buying in bulk, or medicine supplies and paying for those things. Next slide. Next slide. So those who have food insecurity are more likely to actually have a higher LDL, more likely to smoke, less likely to engage in physical activity, and have more emotional distresses. Next slide. So one thing we can do as providers, if you ask this simple question, you might hone in on why things aren't as controlled. Just saying, in the past month, was there any day when you or anyone in your family went hungry because you did not have enough money for food? And that can bring about a big discussion. And so as providers, we also have to devise a plan that's realistic, that's personalized to them as well as to their cultures. We have to take into consideration, finances, the types of meds they're on, and trying to help them find ways to be secure, not only in food intake, but shelter and the necessary things to live. Next slide. So an individualized plan that should also suit the whole family, because if they're often eating together, it's hard to just cook for a certain person with a certain style or types of foods without including the entire family. Next slide. And then we want to talk to them about how to prepare foods. We also want to talk to them about, shifting things in terms of maybe instead of using inexpensive carbohydrates to buy, you might kind of gear them towards maybe buying more frozen vegetables, fresh fruits and proteins, dairy products, things like that, you have to give them examples of what could be affordable and what they can switch out from the higher carb type items. And go ahead to the next slide. Sometimes instead of switching out from, a higher carb thing, you could actually just reduce the portion size rather than substituting for something that's quite not as healthy for the diabetic population. Again, they talk about the culturally preferable items, so you have to think about that when you're devising your plan. And, also just kind of giving them options in the neighborhood or local areas where they might be able to get things on sale, food banks, different options like that where they can help supply the food. Next slide. Next one. So a lot of the medications that we give for diabetes, some of them actually are really inexpensive, like your sulfonylurea class, like glipizide or glyburide. But you do take the risk of low sugars when they're not eating as much. So you have to be careful in the types of meds you prescribe, but also it does create a problem sometimes because maybe that's all they can really afford. So what you can do is if they feel like they're not going to get enough intake for the day, they can sort of treat it as a sick day with diabetes, where they're not taking as much as their medication as they normally would. Metformin is a nice option if they're able to take it. It's usually pretty inexpensive. There is some side effects, including the GI upset, mostly is what I see, but also it's very neutral in terms of if taken alone, as well as your like DPP-4 inhibitors such as Januvia, it's a very low risk for hypoglycemia when just used alone. If you're using it with other things that can cause low blood sugars like insulin, then you have to take that into consideration, but those alone would actually be good options. If you already have them on basal bolus regimens, you're going to have to allow them some flexibility in terms of cutting or omitting doses if they're not actually eating as much. And sometimes we hate to do it, but we have to make our targets different just to mitigate the risk of hypoglycemia. So, when we do these things in our clinic, at least, I have a great group of nurses here that know a lot about insurance coverage and kind of know the ins and outs. So the first thing I usually will go to them and say is, this is what I would like to give them to treat them, but what's covered under their plan. So if you have a good staff there that can help you figure out what's on formulary, sometimes that's really helpful. And, they've taught me other things. Sometimes a lot of these companies will have patient assistance programs where you can get medications for very low cost or for free, even depending on their annual income. Next slide. And okay, thank you. So sometimes we think about what we can do to change the way things are. I don't know if all these are offered all over, but offering vouchers for healthy foods, subsidizing fruits and vegetables so they're cheaper at a higher density carb laden food. Instead of that, you could also have some delivery programs. These things, I don't know if any are available around here. I've not heard of them, but it was just a nice thing to think about. If we could offer this to our patients, it would be a wonderful thing. Other programs that you could think about is looking into things where financial incentives are given for low income neighborhoods to stock, healthy, low cost foods to the grocery chains, or even using, vegetable truck stands or farmers markets to help distribute produce. So you could probably check your local area and see if the farmers market does anything like that. I know a lot of restaurants, waste food because they just don't use it. If we could maybe offer that to our patients who are, lacking in that, that might be something helpful as well. Next slide. So things that you can do and tell your patients that might help them is, when you go into it not really having a plan, it sometimes messes up your whole entire day and diet. And that I can even speak to myself, if I don't really have a plan, I'm hungry when I get home, I might just start grabbing everything in sight. So plan ahead. If you shop the perimeter of the grocery store, you're usually going to find the more essential items. Look for what's on sale, buy in bulk, and you can also make sure your patients are measuring foods just to look at the portion sizes on their plates. Next slide. Sometimes we've told patients to make a meatless Monday or a day where, meat can be more expensive, like just kind of pick some days of the month that maybe they will not try to consume the meat. If they're cooking, they can cook in bulk also and double the batch. They can freeze leftovers. Instead of pitching things that might be used for later. The frozen food's a nice option because you can get options that are low in sodium and don't have all the extra additives to it. Some will look on websites and blogs of how to prepare like leftovers so that you don't waste, or other options for healthy eating. And then of course, technology is always on there. With the internet, you can pretty much find anything. But mostly use the internet, I would say, to look for local food banks and things like that to help assist. Next slide. Next slide. So a few things that are inexpensive that they might be able to try, just for whoops, I lost you. Sorry, I was getting logged out of my other screen and it took you off of mine. So you can look at frozen foods, eggs, tofu, low-fat cottage cheese, canned tuna, nut butter, and seasonal produce. Those are a few things that will be more budget friendly. Next slide. So what I try to do first is if I have a patient that I think there's an issue, I will contact our social worker. They're really a great resource that can kind of hone in on what really truly is the issue, and they may be able to outsource to different people to help the patient. Our diabetes educators, are super helpful. They know all the ins and outs and just lots of information, practical information that helps patients as well. Sometimes we can sample medications if we have those samples, if we're allowed to have them. Oftentimes I'll say, go back to your primary office. If they offer samples, if we don't have them here, they can try that. They have also the Walmart $4 drug plan, and other pharmacies sometimes will match that if they have certain meds that are cost effective, or rather at a lower cost for patients, such as like metformin. Some will be on that list as well. That's less expensive. We can also access the patient assistance programs if you meet criteria in terms of your annual income. Sometimes you can get assistance, and that's even in our Medicare patients who meet the donut hole. Lots of areas have free diabetes education classes or support groups. So helping those patients, find those areas where they provide that sort of class. Using leftovers, try not to waste food, and just basically using any online resources that you can use to assist your patient in helping them. Next slide. So if you just go into Google and type in food bank or food pantry, there's an entire list of all these areas, and I'm sure there's more if you click on the red little whatever that's called. They had a whole list of phone numbers and addresses. I just couldn't get them on one screen, but that would be a nice way to even just have that available to your local area on a sheet of paper in your offices, just for patients who might be a little embarrassed to ask about it. Next slide. And it's amazing to me that over 250,000 people struggle with hunger in the state of West Virginia. There is a way to donate or help with this. If you go to this site, map.feedingamerica.org, and you can donate to the site. Next slide. Any questions?
Thank you so much, Renee. That was really wonderful. And I truly appreciate you sharing those resources as well. And it's so cool how you can just Google food pantry in your area, and it'll have those little red pinpoints for you to see and have that visual. Is really nice. So we would truly appreciate you presenting that today. Did anyone have any questions for Renee or comments, thoughts on the presentation topic? Feel free to unmute or chat in and I can read it out for you. Renee, I did want to ask you too, and I know you sort of touched on it with the meal plans and the delivery services and creating a delivery plan and everything, but for patients who live in food deserts, maybe they don't have transportation, or they just don't have access to grocery stores and places with food. What are your recommendations, your top 3 to 5 recommendations for those patients?
That's really tough. So I guess you're saying basically they have to travel pretty far away. Okay. So, if they garden, you can try to see if they would, grow some of their own foods, or just local farmers markets type things. But if they're going to, let's just say they go once a month to the grocery store, they may need to think about bulking up on things that are non-perishable. Probably frozen foods would be a good option, because that they can, thaw those out pretty quickly. And I would probably reach out to maybe some local churches, or establishments where, you might have a sort of a smaller community where they might be able to devise a plan where they could help each other out. And then I would probably see if they have a local hospital nearby where they might know where some of these people go to outreach to the patients in the rural areas. If they have access to the internet, they might be able to apply for the assistance and just reach out to their local providers so that they can help, bring in anything where they can get things at a lesser cost for them, including their medications. Sometimes I will, for their test supplies, Walmart usually has their lowest brand. It's the Walmart brand. It's called Rely On. So their test strips are less expensive. So that's an option. Just I would just do a local, a Google search even, just to look for any areas where they might have Meals on Wheels or a food pantry. Usually those areas will have something. But I think probably the most important thing is they really need to somehow get involved in that local community, because usually those communities are almost like a family. So, the hard part is just, some people are embarrassed about it, So I don't know, that's a tough one.
That was all really wonderful. And you covered it all too in your PowerPoint. So thank you. And I know you mentioned too, like some patients might be embarrassed with like, you know, reaching out for help with things like that, like food pantries and stuff. Do you ever experience patients who might, one of the barriers might be like health literacy, and maybe they just aren't sure what they're supposed to be seeking? What would be your go-to for patients who face that?
Say probably just make it as simple as possible, because, you know, if you tell them to count 15 carbs, that's sometimes very difficult, and even just reading labels. So I'll just, you know, like use the plate method, where you would say, you know, if you take your plate, a round plate, if you'd make half of it like your leafy green vegetables, and about a fourth of it would be your protein, and a fourth would be carbohydrates. Sometimes I also just make it simple, like just reduce your portion size, you know. And a lot of times if you tell them like a half a cup might be a serving of one item, I will tell them to actually measure that out, put it on their plate and look at it, because, you know, even after time, we forget how much a serving looks like. So not even for the health illiterate patients, but, you know, just anybody, it's just like down to basics, you know, just take it down to as basic as you can.
Yeah, that's wonderful. Thank you. And even like you said, for anyone, I know when I grocery shop too, I buy like the green apples and they're so big now. And I heard that now that's not a serving size of an apple. It's much more. So
Right.
it's interesting. Thank you so much, Renee. Any other thoughts, comments, questions from anyone? Dr. Polywall?
Yeah, I have a question. I mean, um, do you get like a letter from like this Meals on Wheels, okay, to really check off all the food items, and specifically if they are on restriction? Like I had a diabetic patient, he's morbidly obese. I mean, he really need to lose weight. And I got the form from the Meals on Wheels to circle, and I mentioned that he should be on low calorie diet, low salt diet, and they said they cannot provide it. And the patient was not happy with me because he said that he cannot cook food.
Yeah.
Okay. So I had no choice but to sign that paper and write that no restriction, because for him it was a situation or he will not get food at all.
Yeah, I think that's probably the most challenging issue, is that sometimes you can only do so much. And as heartbreaking as it is, I guess I would say is to keep them as healthy as they can be and their A1Cs as low as they can be, with, you know, making sure they're still secure and just the basic essentials, you know. I mean, you could talk to him. I mean, with the morbid obesity, I don't, you know, maybe just portion control a little bit, like maybe not waste it, but like if he has a plate, maybe just cut some of those carbs out and save it for maybe the next day. But yeah, that's a difficult thing, because you really don't have much choice in what they give you.
Okay. But do you feel afraid of like putting things on paper that there is no restriction in the food when you know that the patient is diabetic? Like,
Yeah, I think it's a big issue. You know, I think then you have to, you know, they're going to get the food. Maybe just it's now up to them of what the choice they make in terms of how much of that certain item they're going to be eating on the plate. And sometimes you have to, maybe if you're going to have them portion control, the doses need to go down of their types of diabetic medications to match up if it's something that could cause a low. But yes, I would be completely uncomfortable, but I guess I would have to weigh the risk, the benefit, and you know, that's just a really tough thing. Yeah, I mean, the other thing you could try to do is, you know, if they're eating more carbs and he's morbidly obese, trying to get him to be a little bit more active, to counteract some of the things that he's eating and the weight. And a lot of times I do is, the first thing I always tell patients to do is, if you can eliminate any types of liquids that have calories in them, that's best, because they don't need juice, they don't need milk, they don't need, you know, all these high sugar content items. Then a lot of times, you know, very easily they can get weight off if they just eliminate those types of drink items. You know, because they can get their calcium in a multivitamin, they can get it through their food intake, but they don't need, you know, 3 glasses of whole milk a day. You know, that might be a waste, sort of just like empty calories, you know. So if he's drinking a lot of liquid calories, you might think about limiting that as well.
Thank you.
Sure.
Thank you, guys. Any other thoughts or comments? All right, well, if anyone does have any further questions, thoughts, or comments, or even resources they'd like to share with the group as a whole, feel free to shoot me an email as usual, and I'll make sure to distribute it to everyone in the Endo listserv. But all right, thank you so much, Renee. We truly appreciate you presenting this
No
topic.
problem. Thank you for having me.
Absolutely. And so just the last thing is the announcements. Our next session is going to be on February 24th, and we're going to have a guest speaker join us for that session, Dr. Juan Bugueno, and he's going to be discussing how some of his dental patients with diabetes kind of approach diabetes and things like that. So keep an eye out for that reminder, and we'll see you all next time. Thanks again, Renee.
Okay.
Thank you. Bye-bye, everyone.
Good luck,
Bye.
everybody.
Thank you.